Okay, thanks everybody for joining us for our last session on clinical progress and regulatory perspectives for pharmacological strategies to prevent hypoglycemia. I'd like to thank my colleagues at Helmsley Charitable Trust, especially Ben and Conchi, for the kind invitation to moderate today's session as well as to present. And thank you to all of you for putting together this amazing hypoglycemia symposium. My name is Marjana Marinac. I'm with Breakthrough T1D, which is formerly known as JDRF. And it's my honor today to share the stage with my colleagues Karen Hauda from Novo Nordisk, Asger Lund from Copenhagen University, and Richard Liggins from Zuccara Therapeutics. We have a great session planned for you today, where we'll be presenting and discussing clinical progress and regulatory perspectives for therapies designed to prevent hypoglycemia. I'm going to start off our session talking about outcomes beyond A1C, focusing particularly on the consensus definitions for hypoglycemia and sharing the results from a patient preference study that we conducted that gave us the quantitative data supporting the clinical meaningfulness of hypoglycemic events beyond those that are severe. After me, Karen Hauda will be presenting on how health authorities regulate and how health authority regulations and their perspectives on clinical meaningful endpoints can affect the clinical development of therapies. We'll then have Asger Lund, who will cover the key considerations for methods used to identify hypoprevention candidates and how these methods and early phase studies should provide evidence to advance drug candidates into later phase studies. And last but not least, Richard Liggins will share an update on the progress of their ZT01 drug candidate that's currently in phase 1-2 studies that targets the alpha cell to prevent hypoglycemia. We're going to do this session a little bit different today. We each have about 10 minutes for our presentations. We're going to ask to hold questions at the end, which is where we'll do a panel discussion at the end. So with that, I'm going to walk on over to the podium to start things off. Okay, so I want to take a moment. I think it's always important, especially for an organization like ours, to talk about the unmet needs in type 1 diabetes. All people living with type 1 diabetes require insulin, but insulin is not a cure. The unmet needs still remain significantly high. In 2021, there's about 8.4 million people globally who live with type 1 diabetes. And there are projections that by 2040, those numbers could reach anywhere between 13 and 17 million. Average person with type 1 spends about 7 hours a day hyperglycemic and over 90 minutes per day hypoglycemic. Still significant complications for long-term standing diabetes, and the age-adjusted relative risk for cardiovascular disease in people with type 1 is 10 times that of the general population. And we still, despite advances in insulin and the technologies that we have to help manage type 1 diabetes, have a decreased life expectancy with a loss of 16 life years for those who are diagnosed before the age of 10. A little bit further detail, pointing you to the right here in particular, that A1C actually masks significant daily glycemic excursions for individuals with type 1 diabetes. If you look at on the right here in terms of percent of nights with prolonged hypoglycemia, what you can see is that adults spend 11% of nights with a blood sugar of less than 60 for greater than 2 hours. And we're also seeing that for children, adolescents, and young children, those are 8% and 5% of nights spent in a low blood sugar of greater than 2 hours. So why are outcomes beyond A1C important? You know, for so long, and is currently still the gold standard, there is a focus on hemoglobin A1C as a population-based predictor of complications. As CGM technologies and automated insulin delivery systems have come more into the standard of care, back in 2016, when we launched the T1D Outcomes program, what we wanted to make sure is that there was an expanded set of outcomes that reach beyond hemoglobin A1C to better reflect glucose control and how patients feel, function, and survive. Well, why was defining these outcomes important? Well, regulators use those outcomes to evaluate interventions for approval. And as we looked across clinical studies and looked at the information and data driving decisions from both regulators and payers, there was a gap in how those outcomes were defined and subsequently how they were being measured. Evidence and the clinical community are used to determine whether an outcome is clinically meaningful. And we wanted to make sure that stakeholders, like regulators and payers, were taking this information on clinically meaningful outcome measures beyond hemoglobin A1C into consideration in their decision-making and how they assess the risks and benefits or the safety and efficacy of a therapy. So I'm going to focus on the consensus for hypoglycemia. The diabetes community came together back in 2016 and launched the T1D Outcomes Program. And there were several definitions and outcomes that were part of that initiative. Obviously on the screen here is the consensus around hypoglycemia levels. Other outcomes that were included as part of the program included hyperglycemia, time in range, DKA, and patient-reported outcomes. These definitions, these 3 levels that you see here, were adopted in the American Diabetes Association Standard of Care in 2019, and also, as you'll see here from the International Hypoglycemia Study Group, a joint position statement from both ADA and EASD supporting the clinical meaningfulness of level 2 hypoglycemia in particular, and its use in clinical trials and measurement. Okay, now I want to switch. As part of that T1D Outcomes Program, the other thing that we wanted to do was understand patient and caregiver preferences for those outcomes beyond hemoglobin A1C. And there's some interesting data, particularly around hypoglycemia, that we'll get to in just a second here. So this is an example of a discrete choice experiment. What you'll see on the left here is the attributes that were included as part of the experiment. Adults with type 1 diabetes or caregivers of children with type 1 diabetes were asked to select treatment A or treatment B. 9 of these questions were asked, and all these variables were independently mixed. The attribute definitions were based on the consensus, where hemoglobin A1C, time in optimal range, low blood sugar events, and high blood sugar events were seen as the benefits of a hypothetical therapy, and the burdens were the additional monthly personal treatment costs and the average time that was spent managing type 1 diabetes. Because A1C and time in range and hypo and hyperglycemic events are so interrelated with each other, we needed to include some outcomes so that people could make the trade-offs of what benefits they were looking for. Okay, so as you can see here down on the bottom, here are where our attributes are. With the most preferred attribute sort of seen here, that's the first column of each attribute, and then the last column of each attribute is your least preferred. The vertical distance that's between these preferences indicates the strength of the preference for the change within that attribute. What you can see from the adult preference data here, what we were able to show is that the preferences for outcomes that adults with type 1 preferred were reductions in low blood sugar events, high blood sugar events, and also additional monthly treatment cost. Similarly, if we look at the caregiver data for people with children with type 1 diabetes, again, we see that given the choices that were presented, parents most preferred reductions in hypoglycemic events and hyperglycemic events. Let me delve a little bit further into the data here as it relates to hypoglycemic events. So, leaving aside the 3 levels for hypoglycemia that we included in the survey were 5 to 7 level 1 events a week, 2 to 4 level 1 events a week, 5 to 7 level 1 events per week. And then the least preferred attribute was 1 serious event per week, which is a less than 54, plus 5 to 7 level 1 hypoglycemic events. When we take away that serious event, the less than 54, and just looking, those are the gray bars, just looking at the difference between having 2 to 4 or 5 to 7 level 1 hypoglycemic events a week, adults with type 1 diabetes preferred, these modest changes were more important than the changes that were presented for hemoglobin A1C, time in range, and your time spent managing type 1 diabetes. Another way to look at this is that avoiding 1 to 5 hypoglycemic events a week was 5 times more important than achieving your target A1C from being half a point above. Again, similarly as we saw with the adult data, when we asked caregivers, these modest changes in level 1 hypoglycemic events, again, reducing those events from 1 to 5 of those level 1 events per week was more important than the changes that were presented for hemoglobin A1C, time and range, and the additional time spent managing your type 1 diabetes. So what does this mean for the space? Because of the adoption of the hypoglycemia definitions and the recognition of the clinical meaningfulness, particularly of level 2 hypoglycemia, we're now starting to see a shift in how clinical trials are designed, the tools that are used to measure hypoglycemia, particularly CGM, and how the benefits and risks of those therapies are assessed. These are the two guidances from both EMA and FDA that look at therapies for glycemic control for diabetes, and both of the guidances recognize the levels 1, 2, and 3 hypoglycemia definitions that have been widely adopted and are part of the consensus. And we're also seeing the regulators consider how to use efficacy based on hypoglycemia endpoints to approve therapies for glycemic control, but also for prevention of hypoglycemia. So we've made strides. It took some time, but we're heading in the right direction. And with that, I'm going to turn it over to Karen Hauda, who's going to talk about how those health authority regulations can impact clinical trial design. Karen.
Hi, I'm Karen Hauda with Novo Nordisk, and I'd like to thank the organizers and Marjana for asking me to join this panel. I'm going to switch gears from what you're used to seeing today a little bit, in that I'm going to really dig a little bit into the regulatory guidelines at a high level and try and give you a feel for the impact of what happens clinically in treatment outcomes versus the way the regulators look at outcomes for approval purposes, which are not necessarily aligned, and give you a feel for what we need to do evidence-wise in order to move aspects such as hypoglycemia definitions and time and range into regulatory approval considerations. So as Marjana indicated, you know, the FDA and EMA have both integrated the definitions of level 1, 2, and 3 into their guidances. And this is mostly EMA's language from their guidelines, but FDA guidance also includes the severe hypoglycemia, clinically significant or important hypoglycemia, and hypoglycemia alert value as level 1, 2, and 3. EMA gave specific names to it: the severe hypoglycemia, clinically important hypoglycemia, and hypoglycemia alert value. We tend to reference and prefer clinically significant hypoglycemia for level 2 as opposed to clinically important. Whether these distinctions and nomenclature have a meaning or not. Sorry, I knocked that off. I won't be using it. Have a meaning or not, I think, you know, depends on the regulatory look at it. And FDA chose, and it was a, nearly 9-year discussion with FDA back and forth before they adopted these definitions in May of 2023, as to whether they wanted terminology to their definitions or not. And so I think the levels are identical. How the regulators look at it pretty much are aligned with regard to the definitions and the application of the definitions. But then when you move forward into other aspects, HbA1c still remains the gold standard of measurement for validation of efficacy endpoints. And a lot comes down to what do we consider, or what do regulators consider to be clinically meaningful? And a clinical outcome, necessarily for treatment purposes, that even has consensus is not necessarily adopted as a clinically meaningful outcome for regulatory approval purposes for drugs. And I'd like to give a little bit of a feel for that. With HbA1c, we had to do a 10-year DCCT study to validate HbA1c as a surrogate endpoint for approval of drugs. And that surrogate endpoint, meaning you needed to demonstrate a link between microvascularization issues and the HbA1c. It is now the gold standard, has been used for many, many years. It is considered the validated endpoint and run in every single clinical trial that is done. It reflects a weighted average of the blood glucose over the preceding 2 to 3 months, as you all know, measures at least 12 weeks of stable dosing, validated assay through national and centralized laboratories. And I want to comment on that because as we move towards decentralized clinical trials, you know, how we measure this through national laboratories might become more problematic. Primary efficacy endpoint is typically a change from baseline in A1C to 6 months after randomized treatment. Time and range, which Marjana talked about, there are consensus standards that were published by key opinion leaders and hypoglycemia experts in diabetes care in 2017. And then the clinical targets were published in diabetes care in August of 2019. And arrange those. However, within the guidelines of the regulators, they're not yet considered validated as primary endpoints. And so the big question becomes, how much evidence and what evidence do we need to build in order to get time in range and time below range and time above range as validated endpoints for measurements? And there's no question within the guidances that both regulatory authorities have indicated the advantages of CGM systems. They talk about nocturnal hypoglycemia, the advantage of CGM over limiting bias, which is extremely important in running a clinical trial, and the continual data collection. The regulatory requirements to validate the clinical trial collection, however, remains unclear. And despite the evidence that has come out and publications indicating that time and range seems to demonstrate as a surrogate, at least microvascularization too. So we need to better understand what regulators want in order to move time and range towards a better primary endpoint. Why do we want a primary endpoint? Because the number of points that you get in CGM and data collection actually have an advantage to not running and better powering a study with fewer recruitment patients and getting the data quicker and faster. So that would be one reason. Trial design considerations for hypoglycemia. I'm not going to go through these in detail, but I wanted to outline, you know, some of the aspects that regulators look at. This will be important as Asger and Richard present some of the data that they are looking at. But it's rigorous methods for collection of level 3 hypoglycemia. Both incidence and event rates should be collected and reported. With regard to SMBG and CGM systems, and I talked about bias, the blinding of the hypoglycemia measurements may become very important with regard to regulators. If a patient or a person with diabetes is already on CGM, in order to run a clinical trial, you actually have to have a blinded CGM, and the person may actually have to wear 2 CGMs, their own CGM and one for the clinical trial. And a minimum of 70% expected CGM readings should be captured over at least 2-week period. But then there's questions as to whether the 2-week period is enough, especially when you're looking at time below range, which can be infrequent outcomes. Primary versus secondary endpoint, as I indicated earlier, HbA1c is the gold standard in primary endpoint. Level 3, severe hypoglycemia, is also a very well accepted primary endpoint because of the nature and the lack of bias in the adjudication that takes place around it. More recently in the guidance, level 2 and level 3 composites, meaning combination of level 2 hypoglycemia and level 3 hypoglycemia, can be accepted. However, level 2 is still considered a surrogate, and FDA at least has indicated that level 3 hypoglycemia you need to have enough events of that in order to have a composite endpoint. Accepted secondary endpoints include fasting plasma glucose, postprandial plasma glucose, and CGM metrics. So as a question, just to get us started on the Q&A that might come, I've laid out some questions here. The biggest one for me is, is it harder to adjust established metrics for a chronic disease such as diabetes with multiple effective treatments, and should it be? And is there a better way to assess approval for individual glycemic variability for people with diabetes? Regulators set benefit risk and look at safety and efficacy, but can these endpoints that are clinically accepted and used on a daily basis for patients be moved better into the regulatory environment for regulatory approval? But the fastest aspect is, how do we ensure the regulatory environment keeps pace with the science and we don't have to wait 9 years in order to have the definitions that were defined and gather data over time take that long? Can we move it and speed up our progress? Thank you.
Thanks, Karen. Now I'd like to welcome Asger Lund from Copenhagen University Hospital, who will be talking about clinical trial designs to identify hypoglycemia prevention candidates, considerations, and challenges. Asger.
Yeah, thank you very much, Marjana. And I want to thank the organizing committee and also the Helmsley Trust for inviting me to give this talk. It's about the clinical trial designs we typically use to identify hypoglycemic prevention candidates, and also to touch on some of the considerations and challenges we face when we are designing these early proof of concept studies. And here are my disclosures. So I want to start by showing this study published more than 50 years ago, showing something that we have, I think, concluded many times throughout this day, that patients with type 1 diabetes lack an appropriate glucagon response to hypoglycemia. Right? So what John Garrick also elegantly showed here 50 years ago was that while the alpha cells don't respond to hypoglycemia, they do respond quite fine to an arginine infusion, as we've also talked about quite a lot today. And this trait is something we think happens quite early in the disease progression, which is shown here by this study of Ciafricas in 2012, where they showed that this lack of glucagon response was lost at a median duration of diabetes of 8 months and even as early as 1 month after diagnosis with type 1 diabetes. And again, in this study showed that these alpha cells respond with glucagon when you infuse arginine in these patients. We also had the opportunity to look at arginine-stimulated glucagon secretion in this study, the MAGIC trial with 80 patients with type 1 diabetes. Again, we saw fine glucagon secretion when infusing arginine in an arginine test. And what we also found here, interestingly, was that this was independent of duration of disease, of HbA1c, age, and even beta cell secretory responses. So not hypoglycemic, but to an arginine test, right? So, but I think this still really alludes to the fact that trying to resurrect the diabetic alpha cell is a very interesting therapeutic target. So Going on to the experimental hypoglycemic studies, then the gold standard way of doing these experimental hypo studies would be the hyperinsulinemic hypoglycemic clamp. And I say it's a gold standard method because even though it is quite standardized, the method, then it comes with a huge variability when designing these hypo clamps. And I think just today we have seen examples of 4 to 5 different hypoglycemic clamps being conducted. And I think we really need to think about how we design these hypo clamps when we examine our drug candidates. Overall, there are 2 designs, the single-step clamp and then a stepped clamp with multiple decremental glucose targets, as you can see here. And then the hypoglycemic clamp procedure or phase have like 3 phases we really need to consider. So there's a run-in period, the hypoglycemic phase, and a recovery phase. And some of the considerations of these hypoglycemic clamps, especially for the run-in period, would really be to look at the standardized lifestyles of the subject that we are examining. So I believe we need to think about meals prior to the experimental days, alcohol intake, exercise, prior hypoglycemic events, which we've also talked about earlier today, could be important before we are going into the hypoglycemic phase of these studies. Then we need to think about the plasma glucose target. To minimize variability, we need to have the subjects within a pretty tight, I think, level of plasma glucose before we start the hypoglycemic phase. And how to do that? This really ranges from study to study. Do we have the patients sleep overnight and then clamp plasma glucose? Or do we, as most studies do, I think also more convenient, do small boluses of insulin and glucose to titrate plasma glucose into the range we have predefined before going on to the hypo phase? And then, of course, the duration for how long should they be at this plasma glucose level. I think the EMA has done some advices for the hyperinsulinemic euglycemic clamp that they should be at target an hour before we start the hypo phase. And I think we could talk about having some of the same guidelines for these hypoglycemic clamp procedures. And then the hypoglycemic phase. So how do we drive the subjects down into hypoglycemia? And here we really need to think about, especially I think, the insulin infusion. Should this be a constant insulin infusion with a variable glucose infusion on the side to reach these plasma glucose levels? Or should it be just a variable insulin infusion with no glucose on the side? And I know Richard might touch upon this later in his talk as well. Because I think these 2 methods also could give some different readings and outcomes when we are looking at our endpoints in the end. We need to consider the glucose nadir of these trials. When you look at hypoglycemic clamp studies, then it ranges very much from 2.0 up to 4 point something, the nadirs. And of course, this might also really affect the results that you get from your study. And what Karen and Marjana just elegantly showed, I think, is that I would advocate for choosing a glucose below 3.0, going to clinically relevant by the hypoglycemic study group to be a target to reach for. But of course, it also depends on what kind of subjects you are examining. Is it kids or is it adults and so on? And then the duration of the trial, of course, needs to reflect or be long enough to show an effect of the candidate or drug that you are examining. And then the recovery phase, which is actually also quite important to do some considerations about how to look at this phase. Do we just stop the insulin and glucose infusion from the hypo phase and then look at time to recovery in this phase? Or do we give a bolus of glucose to stop the hypoglycemic period, or even do a stepped glucose phase in the recovery phase as well? So I think a lot of considerations, and we say it's a standardized procedure, but actually it varies quite some when you look at how these procedures are done from study to study. And then we also have to think about the endpoints in these hyperinsulinemic, hypoglycemic claim procedures, because should it be glucagon concentrations or glucagon secretion, or should it even be endogenous glucose production with tracer methodology, as we have also touched upon earlier at this symposium, with also all the challenges it comes with these tracer methodologies, especially in hypo claims. Should it be glucose infusion to rescue, insulin dose to reach hypoglycemia, especially if it's a variable insulin infusion, or time to plasma glucose recovery, as we often see in studies looking at new formulations of glucagon, for instance, in these trials. We need to think about patient selection. Of course, we need to, or the best thing to examine would be the patients we want to examine, right? So patients treated with insulin prone to hypoglycemic event. But for these studies, it could also be healthy control subjects, right? But I would, for these early clinical studies, really advocate for choosing as homogeneous a group as possible to reduce variability. I think we need to think about age, biological sex, and disease duration, as well as glycemic control, C-peptide levels, as we have talked a lot about today, kidney function, and hypoglycemia awareness, which we all know, or things that could, or things that have been shown to, could affect counter-regulatory glucagon responses. All right, and then of course there are other experimental hypoglycemic study methods besides the hyperinsulinemic hypo claims. Often that is studies trying to mimic more real-life situations where you don't have like a claimed situation, but more real life, where you give, for instance, a too high dose of insulin to your meal, and then drive patients down in glucose with their exercise, of course, under very controlled conditions, and then look at your counter-regulatory responses in a setting like this. And of course, this comes with the great advantage that it mimics real life, I think, a bit more than just having way too much insulin. But of course, it also induces quite a lot of variability in the design, so firm conclusions might be a bit harder to gain from these studies. And then, of course, with technology as it is advancing, and especially CGM is becoming a much more good tool to examine hypoglycemia as well. Then, especially moving into the phases, these the CGM studies would be, of course, very, very interesting to look more into. So, with that overview of some of the hypoglycemic trials or designs that we could use, I think we can say that there is substantial variation in the design and conduct of these hypoglycemic studies. This really gives a flexibility in the study design. It allows us the endpoints to be tailored to the specific candidate or drug that we are examining. But it also complicates comparisons of effects between studies, I think. And we really need to remember this when we are looking at effects of different drugs that we are testing. And I believe that a universally accepted standardized protocol for instance, the hyperinsulinemic clamp would facilitate better cross-study comparisons. And with that, I'd like to say thank you and let Richard have the next talk.
Thanks, Asger. Now we have Richard Liggins from Zuccara Therapeutics, who will be talking about their ZT01, a somatostatin receptor 2 antagonist, targets the alpha cell to restore glucagon counter-regulation and prevent hypoglycemia, a phase 1 and 2 clinical update. Richard.
Okay, well, thank you for the introduction, and thank you to the organizers and Ben and Conchi for the kind invitation, and also to the Helmsley Trust. Really, I think for this event is a great example of just how the alpha cell research community has become so much more formed into a wholesome community over the last several years that the alpha cell working group has been in place, and meetings like this have been occurring, and I think it's a valuable thing for all of us together to have had that investment to bring us all together, and so I do appreciate that. So I have the advantage of going last, which means you've already seen most of my slides, some of them a few times. And so I won't belabor some of them, and I guess it'll allow me a bit more time to go into some topics later on. And so Rui having done a great job of introducing this, I won't belabor the point, but of course we're focused on targeting the alpha cell, specifically addressing excess somatostatin secretion that occurs in type 1 diabetes in times of hypoglycemia. And so our hope is that an antagonist would be effective in preventing hypoglycemia, in particular in the environment where the beta cell signaling is absent from that intercommunication, both hormonally and through electrocoupling of the cells, as it is in type 1 diabetes. So I guess at the risk of oversimplifying, the somatostatin receptor antagonist, we hypothesize that this approach will be beneficial in restoring the counter-regulatory response to hypoglycemia, which is impaired in diabetes, preventing hypoglycemia in people with type 1 diabetes. And really what we're trying to do is reestablish a normal equilibrium, or approach that normal equilibrium of somatostatin that does control the alpha cell and becomes excessively blocking of glucagon secretion in times of hypoglycemia and type 1 diabetes. So adjusting that tonal control, if you will, so that things will occur more normally, in particular during low blood sugar events. So our molecule has gone through many animal studies showing that we can increase the counter-regulatory response, and Mike Riddell has published many of those studies already now, both in type 1 animals and also in a rat phenotype of advanced type 2 diabetes, where beta cell function is also noticeably absent. And based on that, we progressed into phase 1 studies, and so our first attempt to demonstrate proof of concept for this mechanism of action in humans was a hypoglycemic clamp. And so, and Mike Rickles, I think, previewed this slide for us as well. We evaluated 24 subjects in a randomized, double-blinded 3-way crossover clamp, where each subject underwent 3 procedures in randomized order, being treated with placebo, 3 or 20 milligram of ZTA1, a somatostatin receptor 2 antagonist, during the clamp. Most notably, this is a variable insulin infusion clamp, and Asger just talked about the various approaches of how insulin can be administered, and I don't think he, maybe he's being kind to me by not mentioning that this really is the minority position, I would say. So if there's a standardized procedure, it'll be to rein me in, I guess. The variable insulin infusion approach has some benefits, but also takes us away from the ability to compare to results from other studies in some respects. But I'll show you some data that I think illustrates why it's an interesting approach nonetheless. Because we're using the minimum insulin requirement to induce hypoglycemia, there's no external dextrose infused in these patients. So by varying the insulin infusion, we can bring individuals first into euglycemia, where we treat them with the experimental therapy, and then after stabilizing them through that, drop them down into hypoglycemia, first to around 3.5 millimolar, which is level 1, or that mild to moderate hypoglycemia that Marjana mentioned in the patient preference work, where we started off. And then after that, down into level 2, or that serious hypoglycemia that patients are really keen to avoid. It's symptomatic hypoglycemia for most people, as long as they have intact awareness. And as we do this, we monitor glucagon throughout, and of course we monitor blood glucose as well throughout. So our primary endpoint is the glucagon response. So I won't summarize. I guess Mike introduced the primary endpoint being statistically significant and elevated glucagon relative to placebo at all stages of the clamp. But I'll show here instead a representative single subject. In the crossover design, every subject is functionally their own control. And so you can see On the left, the placebo, where blood sugar is on the top of the graph, is declining through euglycemia, through level 1, and ultimately level 2 hypoglycemia over the duration of the clamp. In the middle, you can see a rather modest glucagon response, perhaps a little uptick as we get down into the more severe hypoglycemia. And at the bottom, you can see the cumulative insulin dose that was required to induce hypoglycemia. And as we move across the slide, you can see that as the dose level of ZT1 is increased, most noticeably, our glucagon response becomes more robust as we move along, and the insulin requirement to induce hypoglycemia was also increased, about 35% on average. All of our subjects, we were able to meet the target levels for euglycemia and hypoglycemia at each stage of the clamp, despite using only insulin to control their blood glucose. And you can see that glucagon was increased, and statistically so, relative to placebo. We also saw increases in glucose. And so because we're not using exogenous glucose, any rises that we see are as a result of endogenous glucose production, which tells us that the glucagon secretion that we're seeing is correlating with, or is physiologically relevant in terms of enough glucagon secretion to affect a change on glucose. Of course, we overcome that by just increasing the insulin dose further to drive them down, given that it's a clamp study. So those data were convincing of the mechanism and allowed us to progress forward now into a phase 2 study. And we have initiated what's called the ZONE study. It's a phase 2A study, crossover design, where subjects undergo 2 blinded 28-day treatment periods where they receive either placebo or ZT1 in random order, and we're evaluating 3 dose levels of the drug in this study. The primary endpoint is now no longer glucagon, but rather the reduction of hypoglycemia measured as a reduction in the event rate of level 2 hypoglycemia. So when blood sugar drops below 3.0 millimolar. This is a CGM detected event. Blood glucose, if it remains below that threshold of 3.0 for at least 15 minutes, will count as an event. And of course, we can collect all of the CGM metrics as well, since the data is there, and so they're all available as secondary endpoints. In terms of inclusion criteria, this is a study in type 1 diabetes for individuals who have been diagnosed for at least 5 years. They should have a lack of counter-regulatory response, and so the drug mechanism would fit their condition. And importantly, they have to be at risk for nocturnal hypoglycemia. This study is focused on preventing lows in the overnight hours. Nocturnal hypoglycemia is also defined as a standard between midnight and 6 a.m. And so we began the study by identifying people at risk for nocturnal hypoglycemia by including people who had CGM detected level 2 events in the prior month, prior to entering the study, on average at least 1 per week. This was the initial inclusion criteria. We subsequently amended the protocol to change that definition. And now we look for people who are not meeting clinical target for hypoglycemia exposure. And that is they're spending 1% or more of their day, of their 24-hour day, with their blood sugars below this 3.0 millimolar threshold. And so this is a not insignificant change, but actually gets us to the same place of finding people with about the same risk of nocturnal hypoglycemia. And so why did we do this? This is what CGM data looks like. If you haven't seen how the data are consolidated over, if you collect data for 14 or 28 days, it becomes averaged, and this is what the report will look like. It's a time-based series of metrics. The top level is for how much time people are spending in each regime of low or target or high blood glucose. And then the 24-hour averages for midnight through to the following midnight, on average, where's their blood glucose sitting. And so clinical targets have been established. The targets for low blood sugar are 4% of your time, not more than 4% of your time spent with blood glucose below 3.9 millimolar, and not less than 1% of your time not more than 1% of your time spent with your blood sugar considered to be very low or that serious level below 3.0 millimolar. How does this translate to events? The reason that we actually amended our protocol to not identify events to allow people into the study is that the tools that they have at their disposal, both the patients and the clinicians, are more time-based and less focused on event counting. It's actually quite challenging, it turns out, to count events reliably with the rigor required to accept people into a trial, but they are there. They're just very difficult and challenging to mine out. And so I've blown up the last section of that, the daily glucose profile. And so this is an average of 14 days, and you can see each day represented here. And recapitulating the top of the graph, showing that this individual spent 4% of their time with their blood sugar below 3.0 millimolar, which is quite a lot from a patient experience standpoint. But how many events are they having? Well, you have to look at this profile, and you sometimes need to photocopy it and expand or get a microscope out or some kind of ruler with millimeter gradients to figure out if it lasted long enough and if it was low enough. You can see a red line there. I actually had to draw that on myself because the standard report doesn't even tell you where the 54 milligram per deciliter or 3.0 millimolar cutoff is. But it turns out that this subject experiences quite a lot of events. Here you can see I've circled the nocturnal hypoglycemic events that this subject is undergoing that correlate with this 4% time below range. So it turns out that it's intuitive that there would be a high correlation, but we've gone ahead and done the math on that, the high correlation of time below range and hypoglycemia event rate. And so you can see that if one is experiencing 1% or more time of their day spent below that 3.0 millimolar level, there's virtually a 100% probability that they're experiencing at least one serious level 2 hypoglycemia event per week. And that's the one event that the patient preference results show us that patients will take a lot of effort to avoid that. I guess maybe disturbingly for patients though, you can see that even if you're at 0.5% of your time below range, you still have a 50% probability of having that weekly hypoglycemia event. And 0.5% sounds like it's not very much, and in fact you would be considered to be meeting target and get a passing grade from your endocrinologist, but you're still 50% at risk for having that event that you desperately want to avoid because it is symptomatic. And so that's work that we presented just a few months ago at ADA, and we'll be presenting some more of that coming up in the fall. But I think this is an important piece that we need to link this time-based metric that is how CGM drives us to think with event rates that the FDA requires us to measure and show to demonstrate that a drug is having a benefit. And so that's, I guess, my parting shot, which I think, at least I hope, will spur some comment and discussion in our next segment for questions and answers. So thank you.